study for effectiveness in prevention of postoperative hypocalcemia of preoperative oral supplementation of vitamin D in patients undergoing total thyroidectomy, a multi-center randomized control trial. Present Dr. Ra-Yeong Song, if I'm right.
Yes,
and
you're
thank
right.
you for being here from Korea.
Thank you. Thank you very much for the kind introduction. It's an honor for me to be able to present my study from Korea. I'll be presenting the findings of a randomized clinical trial that we performed to evaluate the effectiveness of preoperative high-dose vitamin D supplementation in preventing postoperative hypocalcemia in patients undergoing thyroidectomy. So one of the most significant complications following thyroidectomy is hypocalcemia, primarily due to either transient or permanent parathyroid dysfunction resulting from surgical trauma, ischemia, or accidental removal. The prevalence of post-thyroidectomy hypocalcemia varies depending on the extent of surgery, with total thyroidectomy and central neck dissection being associated with a higher risk. And in severe cases, symptoms may include muscle spasms, tetany, and cardiac arrhythmias. So treatments include IV or oral calcium with calcitriol. Doses should be increased according to severity of symptoms, and consequently, more biochemical tests and sometimes increased hospital stay as well as readmission rates result in higher financial burden for patients with post-thyroidectomy hypocalcemia. So vitamin D plays a pivotal role in maintaining calcium and phosphate homeostasis, but controversies exist on whether perioperative vitamin D deficiency is an individual risk factor for postoperative hypocalcemia. However, there are several studies that have suggested a potential role for preoperative vitamin D supplementation in reducing the incidence of post-thyroidectomy hypocalcemia. So the debate continues regarding the most effective approach to prevent and manage post-thyroidectomy hypocalcemia. So in this present study, we aimed to investigate whether preoperative administration of high-dose vitamin D can effectively mitigate the risk of hypocalcemia following total thyroidectomy, thus improving postoperative outcomes and patient recovery. So this multicenter prospective randomized controlled trial was conducted on patients undergoing thyroidectomy at the Department of Surgery, Seoul National University Hospital, and Department of Surgery, Chungang University Hospital between June 2021 and March 2024. Ethical approval was obtained from the institutional review boards from each hospital, and this trial was registered at clinicaltrials.gov. So patients of age 19 to 70 scheduled for total thyroidectomy due to benign or malignant thyroid nodules as well as Graves' disease were recruited and randomized in the outpatient clinics. And exclusion criteria included patients with concurrent hyperparathyroidism, pre-existing hypocalcemia or hypercalcemia, chronic kidney diseases, and other conditions affecting calcium metabolism were also excluded. Patients already taking calcium or vitamin D supplements were also excluded from the study. 30,000 IU of oral cholecalciferol was administered 15 days before surgery, and the primary outcome was the incidence of hypocalcemia after total thyroidectomy. Secondary outcomes included the severity and duration of hypocalcemia and patient-reported outcomes related to calcium status. Hypocalcemia was defined as serum calcium level below 8.0 milligram per deciliter or requiring symptomatic treatment or supplementation. Hypocalcemic symptoms were classified as none, mild, moderate, severe, or tetanic. Patients reported mild symptoms when at tolerable levels. Moderate symptoms were those that improved with calcium supplementation, and severe symptoms were reported when there was no improvement despite calcium supplementation, requiring an increase in dosage or IV calcium. So total thyroidectomy was performed through the open conventional method, the robotic bilateral axial breast approach, and the transoral endoscopic thyroidectomy. All surgeons were highly experienced in all three techniques with similar surgical training backgrounds. If a parathyroid gland was inadvertently removed, autotransplantation was performed. So thyroid function tests, serum calcium, vitamin D, creatinine, and phosphorus levels were measured at the time of randomization. Vitamin D was remeasured 1 day before surgery, along with PTH and serum calcium. PTH and serum calcium levels were assessed 1 day, 2 weeks, and 3 months postoperatively in the presence of clinical signs, postoperatively. And in the presence of clinical signs or symptoms, additional biochemical assessments were undertaken at 6 months. So a total of 110 patients scheduled to undergo total thyroidectomy who initially met the inclusion criteria were screened. However, 2 patients were excluded for reasons such as vitamin D supplementation and delay in surgery chosen by the patient. 108 patients were randomized using a web-based randomization method at the Medical Research Collaborating Center at Seoul National University. And patients were randomized to either the preoperative vitamin D supplementation group or no supplementation group in a 1-to-1 ratio by randomized block design. 10 patients were excluded after randomization, mostly due to changes in treatment plan, and a total of 98 patients were finally analyzed per protocol. So 78 patients were female. The mean age of the total population was 45 years, and no severe adverse events of DMAC 30,000 IU were reported. There were no significant differences between the control group and the vitamin D supplementation group regarding indication for surgery and surgical approach. There were no differences in extent of lymph node dissection and parathyroid autotransplantation. Hospital stays were also similar between the groups. As for perioperative measurements, there were no differences between the 2 groups at screening stage. Vitamin D levels on the day before surgery were significantly higher in the vitamin D supplementation group, and vitamin D levels increased from 17.8 to 21.5 in this group of patients. Serum PTH, calcium, ionized calcium, and phosphorus levels were comparable between the groups at all points of measurement. Hypocalcaemia, defined as serum calcium less than 8, was comparable between the 2 groups on postoperative day 1. However, at 2 weeks after surgery, hypocalcaemia persisted in 3 patients in the control group, whereas no patients in the vitamin D supplementation group remained hypocalcemic. So this figure illustrates the change in mean calcium levels over time. Although the differences were not statistically different, the vitamin D supplementation group, represented with the straight line, consistently showed higher mean calcium levels throughout the study period. So hypocalcemic symptoms following total thyroidectomy did not differ significantly between the study groups. However, it is noteworthy that the symptoms were reported as a little bit more severe in the control group. The rates of calcium and vitamin D supplementation were also comparable, but patients in the control group required a higher intake of calcium and vitamin D through, although this difference was not statistically different. PTH and serum calcium levels at postoperative day 1 between the 2 groups were compared. There were no differences in PTH levels below 15 or 10. When calcium levels were subdivided to less than 8.5, less than 8, 7.5, and 7.0, more patients on the control group had calcium levels below 7.5 on postoperative day 1. We also looked into hypocalcemic symptoms according to preoperative vitamin D status, irrespective of vitamin D supplementation. Hypocalcemic symptoms did not differ on postoperative day 1 or at 2 weeks after surgery, but patients with lower vitamin D levels reported more severe symptoms at 3 months postoperatively. The risks of hypocalcemia in our study cohort were evaluated with a univariate analysis. None of the examined variables showed a statistically different association, although a certain trend was observed, and patients with Graves' disease had an increased risk odds ratio of 17.2, suggesting a potential predisposition to postoperative hypocalcemia in this subgroup. Surgical factors such as endoscopic or robotic approach, central neck dissection, and parathyroid autotransplantation were not associated with increased risk of hypocalcemia. So in this study, we found that there were no significant biochemical differences between the control and vitamin D supplementation groups at any point of measurement. The severity of hypocalcemic symptoms was also not statistically different between the two groups. However, there was a trend toward improvement in symptom severity in the vitamin D supplementation group, suggesting a potential clinical benefit that may not have reached significance due to sample size or variability in symptom reporting. But it still was supported by the lower doses of calcium and vitamin D supplements prescribed upon discharge in the supplementation group. This study has several limitations. Preoperative levels of vitamin D were not taken into account, and all patients received the same supplementation dose regardless of their baseline status. Additionally, patients were not blinded, which may have introduced bias in symptom reporting or treatment decisions. Since nowadays we're performing more lobectomies, patients with larger or more advanced stage tumors in need of total thyroidectomy were included in the study. And these patients, as well as Graves' disease, have a higher risk for developing postoperative hypocalcemia. So in conclusion, our findings suggest that preoperative vitamin D supplementation may help reduce the severity of postoperative hypocalcemia and alleviate symptoms in patients undergoing total thyroidectomy. I would like to thank my colleagues from Seoul National and Chungang University. Thank you for your attention.
Thank you very much. Professor Raffaelli, please.
Dr. Song, thank you for your presentation. I'm Marco Raffaelli from Italy, and for sharing with us your data. I'm only a little bit concerned with the type of supplementation you did in the patients, which was cholecalciferol. Cholecalciferol is not an active form of vitamin D and needs to be activated in a PTH-dependent process. So in those patients who are going to have an hypoparathyroidism, so in your group, I mean, I guess 13 patients in one arm and 18 patients in the other round, there is, at least in principle, no benefit we can expect from this kind of treatment. So in my opinion, I would like to have a sub-analysis of this patient who were hypoparathyroid following the operation and look at this group of patients if they would have any benefit of this kind of supplementation with respect to another counterpart of supplementation, which is calcitriol, which is more active for this patient who are hypoparathyroid following the operation.
I definitely agree with your comment, but we usually, we looked into the type of supplementation to give. There were a couple of research before us that their presentation with their study with the cholecalciferol, so that's what we chose.
Okay, but if you can try with calcitriol or alpha-calcidiol in order to see if you have some benefit starting before operation. We presented this meeting in 2021 a preemptive administration of calcitriol before surgery, and it was effective in preventing symptoms and signs of hypocalcemia in those patients who are hypoparathyroid following the operation. So it would be probably more cost-effective to give an active form of vitamin D rather than a non-active form that should be activated in a PTH-dependent process. Again, thank you for focusing on this particular topic.
Thank you for your comment.
Okay. Yes, Professor Jacobone, but we want to be a little bit fast in our questions since their time is a bit restricted now.
Very quick question. Have you performed the statistical calculation of the power? How many patients do you need to have some statistically significant results? Because I don't know if 49 per group are enough. And the second question is that finally you have no statistical variation in PTH level. So we are speaking about hypocalcemia, but not about hypoparathyroidism. Is it correct?
Yes, it's correct. We did do a statistical analysis for the number of patients, and it was 49 patients for each group. So that's how we got to this number. Yes, all the numbers were not significant, but that's a point to consider. Thank you.
Okay. Very fast.
Super fast. Lere Lorente from Barcelona. Thank you very much for your study. I just wanted to know what is your policy of supplementation of these hypocalcemic patients after the surgery?
We do have a protocol. We unified the protocol for both hospitals. When patients have mild hypocalcemia, when they have mild hypocalcemic symptoms, we give them calcium 500 milligrams 3 times a day, and vitamin D 0.5.
So you based the supplementation on symptomatic, not on based on the biochemical results of the blood test?
We sort of combined the biochemical results as well as the patient symptoms. So even if the patient had normal levels, when they had symptoms, we supplemented them with calcium.
Okay.
Thank you.
Thank you.